Hey folks, and welcome back. This is the Doc Buddy Journal. I'm your host, Eric Sunset. We are recording this episode today on Thursday, October 19th. This is episode 40 of the Doc Buddy Journal. So thanks for listening along as the show has grown and evolved. It's been a lot of fun to get to episode 40, and here's to many more of them. And this week we're back after spending a couple of great days in West Palm Beach for the Bone Society of Florida annual conference. Shout out to Lindsay and Frazier for hosting another fantastic event. And this week is kind of the calm before the storm before the Becker's ASC event in Chicago next week. Be sure to visit Doc Buddy while we're all there together to see OpNote, to see surgery workflow. That way you can revolutionize your facility's operative report process. Happier surgeons, happier staff, faster revenue cycle. What's not to like? So we're booth number 210, which is on the left-hand side of the exhibit hall. We hope to see you there. And for this week, we want to cover the hottest tweet in health IT. I guess it used to be called a tweet. Now the platform is called X. I'm still going with tweet. I don't know what to call it if it's not a tweet. But this particular thread is coming from a guy called Will Menditis, who's the CEO of Science.io. It's got a really alluring first tweet here. Healthcare is having its top deck of the Titanic moment. Is it? Let's see. For full disclosure, we don't have any affiliation with Science.io. Don't know anybody that works there. Don't have a relationship with Will personally. But the top line of their website says that their AI transforms medical text into enriched data so that you can build solutions that improve patient care. Turning our attention to the tweet thread, it's gotten almost 2 million views at the time of recording. The thread's only a couple of days old. And for those that aren't familiar with a tweet thread, you can obviously have just a single tweet that goes out into the internet. Or you can make it more of a long-form tweet with a series of them. So when I say tweet thread, I'm just referencing a series of tweets all on the same topic. And we thought this was a really interesting take from Will. This is much more through the tech lens. So think Silicon Valley, think traditional technology vendor as opposed to the traditional health IT vendor, and through that lens, if that makes sense. This is a lot more of a disruptive point of view, as opposed to something that already exists in either legacy health IT or established health IT, where you're seeking to improve an existing framework or an existing process. This is much more of a disruptive look, like we said. So in pulling up this thread, we're going to go through it, and then we've got some thoughts, we've got some devil's advocate points, a couple critiques maybe. It's all in good fun. This isn't meant to be an assault on the essay that we're going to go through here. But there is a very distinct difference between those on the outside of healthcare seeking to disrupt versus those that are in it, either doing the disrupting themselves or simply looking to improve physician workflow as a part of the system, right? So let's go through it. Healthcare is having its top deck of the Titanic moment. What happens in the next year will define the next century of American healthcare, and basically everyone is ignoring it. Here's the real story. So pretty compelling entry there. We'll define where we think the thesis is correct and where maybe it's not so right towards the end here. So here's the tweet thread in its entirety. Healthcare has been defined by 4 factors. 1, extremely limited supply. Doctors are scarce and costly. Principal agent problem with payments. Your insurance pays, not you. Inelastic demand and high trust is point 3. So you need it and have confidence in it being healthcare. And number 4, regulatory capture. This has allowed the industry to behave in incredibly weird ways. Cost can constantly grow, patient experience can constantly degrade, and clinics will still fill up with wait lists because patients trust it, need it, aren't paying for it, and have no choice. In the last years, we've seen all 4 of these factors shift. 1, supply is expanding. It's hard to imagine a world where 90+% of care isn't LLM assisted within the decade. An LLM is large language model, think ChatGPT. After years of getting brutalized by EMRs, we're close to doctors having technology leverage. Two, as commercial insurance degrades, patients shift from a payer PCP-centered model to an army of online telemedicine services for each and every condition they might have. This ends with Amazon being your doctor and pharmacy. Cash please, no insurance welcome here. Three, patients have lost trust in the system. This begins with the medically assisted gutting of America with opioids, continues through the pandemic, and the horrible experience in clinics today. The answer is not patients demanding better, it's patients exiting entirely. And that's exiting the traditional healthcare system entirely, just for clarity. Number four, the FDA continues to be slow to regulate new methods of care that blur the line between medical and non-medical. Pill mills and other online cash for prescription schemes are allowed to operate for years while patients increasingly ask for non-medical health optimization. The pieces of the stack that have existing regulatory entrenchment, EMR and so forth, are even stickier than they've ever been. When the agency moves slow, it has the effect of allowing capture to persist and entrench to absurd degrees. There's no world where we untangle these. And I think Will is right there, but not necessarily for the reasons he's giving. We'll come back to that. Yet, I just spent the last month bouncing between various healthcare conferences and the party goes on. We have free, physician-quality artificial intelligence inbound, and the most interesting question the industry can ask is how can this automate the fax machine? The thread continues, no one seems to actually believe that change is coming. The most confident seem to believe that physician scribing will get more efficient if we pour another $1 billion into it. No one is reckoning with the fact that fundamental patterns of care will change. In every case, technology excels at making new firms more efficient than incumbents, setting a higher standard for them to catch up to. Technology struggles to elevate legacy firms to a level that exists beyond their industry. Failure becomes the default and expected outcome. Technology has been a mess in healthcare because, one, tech firms overpromised and underdelivered underbaked solutions without understanding pre-existing workflows. And two, healthcare firms saw their peers trying to adopt and failing with technology, so they safely ignored it. In a world where there is no supply-side competition, no net new entrants, this is a perfect strategy. The issue is this is no longer the case. Patients are now building at an alternative medical system to the side of the traditional one with incredible demand. In the next 24 months, we will see hundreds of novel care schemes pop up that look unlike the healthcare system we are used to. These will be cash pay, often legally gray, and likely mostly LLM assisted. They will provide a better, cheaper, and faster option. Even if you don't believe this libertarian cash pay free market utopia is likely, it is, all you have to look at is the integrated care networks for a hint of what the future looks like. Amazon, Walmart, CVS are already building this parallel care system. It's so over. We are about to see furious competition for every single piece of the stack that has been a monopoly for a generation. From providing care to paying for it, it's all in play. Healthcare has become a technology industry and a consumer one, and no one is ready. So there's some pretty thought-provoking pieces to this tweet thread from Will. There's a couple of things, though, that require at least a devil's advocate's point or at least a counterpoint. And I'm certainly not here to contend that this parallel system isn't happening. It is, and we'll get into detail later. But there's a couple of sort of finer points that, when you get the outside tech perspective, look so obvious to pure, true technology-only shops or technology shops that maybe haven't yet dabbled in healthcare. You can look at some of the massive flops over the last decade, Google Health being the first one that comes to mind. You would have thought that an organization like Google, now Alphabet, could crack the code. They can just throw developers at it, throw engineers at it, let's think this through and come up with a better way. It didn't happen, and it wasn't even close. There was never a doubt that it wasn't going to happen. So let's look at a couple of these tweets in particular, starting with the one that supply is expanding. It's hard to imagine a world where 90% plus of care isn't LLM assisted within the decade. And this is after years of getting brutalized by EMRs. We're close to doctors having technology leverage. A little pedantic on my part here, but are we talking about care being assisted by LLMs, or are we talking about documentation being assisted by LLMs? Because there is a big difference. There's a tremendous difference between the two. We don't want to nitpick the argument because the sentiment is pretty clear that the thesis from Will is that it's hard to imagine a world where almost all of care is an LLM assisted. There's no large language model. That's what LLM stands for, one more time. There's no LLM that can ever perform a physical exam. That's just the nature of the beast. The machine will not go hands-on with you, the patient, to work you up. So if we can look past that, where the tech leverage will really come into play for doctors is if an LLM can not only provide exceptional documentation requiring hopefully ever diminishing amounts of oversight as well, because we know that if a doctor is signing his name on your notes and your charts, whatever documentation in there is the liability of that physician or of that provider. But if an LLM can not only provide this exceptional documentation, but be able to capture discrete data elements in the correct fields within that provider's certified EHR for quality reporting, now we're talking about real leverage. Now we're talking about actual leverage for the doctor to be able to spend less time in their software. I am like a broken record here talking about the number one driver of physician burnout being the software that they are forced to use. And the only software they're forced to use is their certified EHR. But if you can create an LLM that not only captures the documentation needed for like a basic SOAP note, but is also dropping those points for quality reporting into the discrete data fields in the EHR, that's real leverage. That's real change. That's meaningful change in the day and the life of the physician and the mid-levels and all of the clinical team that supports that effort. So when you look at the tweet thread in its entirety, it is very good. It's very interesting, but it really overlooks the reason where we are today with health IT. That's meaningful use. We're going back a decade now, a decade plus. That's obviously evolved into macro MIPS and the many other quality reporting programs and registries that healthcare orgs must submit data to. And by the way, that data needs to be structured a certain way. You're not dumping PDFs of free-form notes into these registries or to CMS. They're looking for data points. And to go back to that initial point, if you can craft an LLM that knows which data needs to go where within a certified EHR, that's real leverage. And point of contention here, EHR and EMR, it's not the same thing. Electronic health records are the world we live in today, where data is interoperable to a degree. And I'm certainly not here to be an apologist for the EHR industry, but EHR is health data that can move. EMR, sort of the old way, electronic medical record, that amounts to a digital silo. So not to pick on our friends from the outside looking in here into the healthcare world that are coming from a tech background, but there is a difference. And choice of words do matter, especially in a tweet where you're limited to a certain number of characters. But coming back to the central point with what really matters, there is no healthcare system without providers treating patients. And really technology should augment that provider and not be a time suck and the primary factor for the entire occupation's burnout, even extending down to nurses as well, who are not a qualified provider in the eyes of macro MIPS. Need to be a physician or a mid-level. But burnout knows no bounds between professional distinctions. Moving on to the next part of this thread that needs our attention is as commercial insurance degrades, patients shift from a payer PCP-centered model to an army of online telemedicine services for each and every condition they might have. This ends with Amazon being your doctor and pharmacy, cash please, no insurance welcome here. For some, this will be true, and really for some it already is true that can afford it. But that's not really most people. That's not making an impact on the bulk of the healthcare consumers in the US. When you look at a little bit of data from the Commonwealth Fund, private insurance is the primary healthcare coverage for 2/3 of Americans, and the majority of private insurance, at 55%, is employer-sponsored. A smaller share, at 11%, is purchased by individuals from for-profit and nonprofit carriers. So this leaves about a third of the insured to CMS-based coverage, so Medicare and Medicaid, and there are huge numbers of baby boomers that are going to be added to the Medicare roster through 2030. The last number I saw is that expectations are at about 26 million new folks joining the Medicare rolls. So that's a ton of people. And this assumption that we're going to be moving to a cash pay for anything that you might need, I think misses the mark a little bit, because where folks either get insurance through their job, they're paying out of pocket, or they're getting it from CMS, are we really expecting a massive shift? And to quote, an army of online telemedicine services that ends with Amazon being your doctor and pharmacy? I'm not so sure. There is a huge amount of pressure on household budgets. So unless trust within the system is completely shattered and broken, it's going to be tough for all of these currently insured Americans to forego their existing coverage in favor of cash pay services. We're not talking about the one-off issue, which we're going to cover in a minute, something that's a one and done. Hey, I need this script written. I don't really need to see my doctor for it, or maybe I don't know this type of doctor, so it's easier for me to just go online. I think that's the exception that proves the rule. I mean, Americans are not well overall, so we're talking about moving from a physician-patient relationship treating some type of chronic disease or treating some type of illness to just getting it online through telemedicine, and I got to pay out of pocket for it, even though I'm already paying through the nose for the insurance I already have? I don't think so. Not anytime soon. And on a little bit lighter note, I got a kick out of these two tweets in the thread. The first one begins, we have free physician quality AI inbound, and the most interesting question the industry can ask is, how can this automate the fax machine? Welcome to Health IT in 2023, man. This is much more commentary, though, on the shoppers and the buyers in the healthcare space than maybe the availability or functionality of new, powerful technology. This is very much a world where it's still using paper film, and you've heard that metaphor from us before. The vast majority of healthcare is using paper film because they don't know digital film exists. So when we're talking about improving and automating fax machine workflows, that's how it's been for the last 15, 20 years. Welcome to Health IT in 2023. And then next, no one seems to actually believe that change is coming. The most confident seem to believe that physician scribing will get more efficient if we pour another $1 billion into it. Well, I think the real change that tech is hoping to affect for healthcare, that it desperately wants to make happen, is severely limited by the aforementioned regulatory entrenchment aspects of the system. Once again, this is quality reporting. And unless as a provider you are already at a cash pay practice, you're beholden to quality reporting, or you're risking a decrease in your reimbursement. And it's really not so much risking it. If you're not participating in any of the quality programs, you are going to have a decrease in reimbursement. And then the final line of this tweet is that no one is reckoning with the fact that the fundamental patterns of care will change. You know, for some, the pattern of care can change for some, and it's those that can afford it. The pattern of care has already changed for those that can afford it. I mean, even looking through the COVID pandemic, there were clinics popping up on every corner here in Miami. If you need a COVID test, bring cash. We'll test you right here, right now. And this is going back to sort of the early, middle days of the pandemic where tests weren't all that easy to come by. But if you had cash, you could get tested right here, right now. We'll tell you if you have COVID. The next one is the tweet that technology has been a mess in healthcare because, one, tech firms overpromised and underdelivered underbaked solutions without understanding pre-existing workflows. And then, by extension, healthcare firms saw their peers trying to adopt and failing with tech, so they safely ignored it. Point one is true. Point one is absolutely true. Overpromised, underdelivered, underbaked, not so sure. But without an understanding of pre-existing workflows, delivering software to the market, I don't know that that really falls to the vendor. You know, and speaking from my old EHR vantage points, workflow is taken really, really seriously by all of the major vendors. Now, you know, there's still 700 some odd certified EHRs in use, So I don't know that I can speak for the entire marketplace, but everything in the top half, certainly the top 25, top 50, workflow is taken incredibly seriously. But that workflow advantage that vendors sought to build into their software was kind of nullified by all of the requirements from CMS around data capture. You have to capture the right data to show us that you're meaningfully using our software or a software so that you can first get a meaningful use bonus and then next just not lose any of our Medicare reimbursement. But all those data capture requirements turn physicians into their own scribe. This isn't some universal failure of a lack of understanding of workflows. I mean, every EHR worth its salt has a chief medical officer to advise on these types of matters. There's not, to my knowledge, a deep state for healthcare that makes so much of this software disaster to buy, to implement, and to use. There's no conspiracy theory that EHRs have to be poor workflow tools. It's a product of ARRA 2009, which is the American Recovery and Reinvestment Act in 2009, which contained the HITECH Act bill. That's the issue. You're turning physicians into their own scribe. You've taken them from treating patients, what they went to medical school to do, and now we got to capture these 25 data points on every encounter. What are you supposed to do about that? There is no technology firm in the country that could solve for that, and they still haven't. Too bad. Too bad for physicians, that is. Not that there is some conspiracy to make health software tough to use. And then point two, that healthcare firms saw their peers trying to adopt and failing with technology, so they safely ignored it. Who safely ignored it? I mean, really the only people that could afford to ignore it, and that is meaningful use, later MACRA, then all of the registries that data has to be submitted to for your specialty, and so on. The only physicians that could ignore it were those on the verge of retiring, those operating a cash pay practice, which really, they don't need to be on an electronic health record at all, at least not in terms of their reimbursement, holding aside patient safety, holding aside outcomes management, holding aside all the benefits that EHRs do bring to patients and providers. But there's no impetus. Nobody said you had to have an EHR. That's all related to Medicare reimbursement. So either you're operating a cash pay practice, you're about to retire, or your Medicare panel was so small that you could afford that cut in reimbursement to not adapt and then meaningfully use that software. Because that's what we're really talking about here, right, is EHRs. We're not talking about rev cycle solutions, which are widely adopted. We're not talking about patient engagement solutions. We're not talking about appointment reminder software. We're talking about ignoring the digital transformation that the federal government has tried to make happen in healthcare and has been successful to a degree, at huge expense, by the way. Again, not an apologist for the meaningful use component of the HITECH Act, but we would still be in a healthcare ecosystem that was largely on paper without that driver. And that's a reality. That's a fact. So when we go a little bit deeper, this parallel system that Will references throughout the tweet thread seems to revolve more around disruptors like HIMSS. And if you watch football on the weekends, you'll have seen a HIMSS ad. If you listen to any podcasts that have advertising on them, you'll have heard a HIMSS ad. But if you're not familiar, HIMSS provides telemedicine services for men with ED, with hair loss, and so on. So with a service like that, this disruptive factor for what would have been your primary care physician or maybe your urologist is you get access to a script writer for these non-essential drugs that you want. You pay cash for it and you move on. And sure, they'd love to sell you a subscription to whatever it is that you purchased, periodic check-ins as required with the physician that's writing the script, and that's it. So that is disruptive. That's taking patients out of their primary care office or their urologist office in the case of HIMSS and so forth, and it's moving it online. So that change is already happening. It's already taking effect. But there isn't going to be a parallel cash pay system for folks with actual medical issues. So how can you diagnose and treat something like type 2 diabetes remotely? Well, you can't, not in a way that will be a better experience than what we've already got. That's not to say it's a good or a great experience in any way. It's just that you're still doing a consult, you're still going to the lab, you're still having blood drawn, you're still waiting for results, then you're going to talk to a physician again. You're going to get on a plan. If you need drugs, you'll get the drugs, and so on. The other half of this is that how far would you have to drive, listener, to get to a CVS Minute Clinic? I've got like 5 that are a stone's throw from my house and even more here in my office. This alternative delivery model it's no longer revolutionary. That revolution has happened, and you'll see continued vertical integration there in the space, absolutely. But the availability of walk-in clinics and urgent care is like that's already there. So in some facets of this thread, I'm not totally sure what we're talking about. I mean, we're talking about how LLMs are going to grease the wheel for this sea change in healthcare, but a lot of these revolutions are already occurring. And at what scale do we expect them to deepen, especially to peel people away from sort of traditional medicine into this alternative parallel model? But all that to say, again, this is not a critique of the thesis. It's interesting. It's given us something really different to talk about here. And personally, I love it when tech takes an interest in healthcare. I love that in America, we exist in a free market where if you have an idea, you can try to monetize it. That's awesome. But the thesis here that LLMs can underpin an alternative to traditional healthcare, though, it shows perhaps some of the naivete of tech when addressing healthcare's many issues. So sure, there's potential with LLMs to solve for scale on a P&L, really. Scale in the sense of healthcare is patient throughput, and even secondary markers of throughput like messages from patients. But it overlooks the physician oversight aspect of the relationship. It also overlooks the legal and compliance aspects of physician oversight for the care and outcomes of their patients. Scale or patient throughput isn't what improves patient outcomes. It just isn't. All that to say, I think Will is right about the parallel cash-only care delivery mechanism, but it's already happening. It's already happening with sites like Hims, with CVS Minute Clinics, with Walmart's clinics, and so forth. But a sea change from the fee-for-service world we're living in is going to take a lot more than the advent of physician-grade generative text software. And this might be more B-roll type material than anything else, but the tweets on X, or the Zeets, if you will, some are calling them, some of the replies to this thread are interesting. They're thought-provoking because you see the advent of LLMs across healthcare. Some are being integrated into widely adopted EHRs. We've discussed healthcare systems leveraging LLM technology for their providers to send replies to their patients with because it's such a drain on their time. So this isn't going away, and I'm grateful for a town square like Twitter that can bring a lot of different points of view to light. So a reply here to the thread: who do you see holding the liability in this new model and system when it comes to malpractice and abusive care? How is that mitigated? I'm a physician who has PAs and NPs under me who make more mistakes in an hour than you can imagine. And the reply from the author is that for telemedicine today, when you get a prescription after going through a structured form, that's 99% machine and 1% human. Who is responsible? How does that change when we 1000x the volume and crank the acuity? NPI holders will act like human liability shields, increasingly inhuman. Who is responsible? Man, right now there's only one person that's responsible, and that's the physician, that's the provider. There's no anyone else to hold the liability there. So that NPI holders will act like human liability shields. Whew, could you imagine being a provider? So, doc, we're going to attach your name to this LLM populated form that a prospective patient will fill out. You don't really need to read anything. All we need is your signature in the ePrescribe module. No chance. There is nobody, no physician will be signing their name to a process like that. Dr. Aryan Nanda replies, sounds like a pretty terrible deal for the physician. How would they be able to accurately assess the differential, consider comorbidities, think through the logistics of the recommendation or the recommended diagnosis and treatment plan when they're given 30 seconds per patient? Why should their license be on the line? And right now it is. There are no laws around consumer or patient protection with the use of LLMs in their care. There's only one party that's responsible. It's the physician. So who's responsible? The replies continue. We are facing a critical shortage of MDs, largely driven by MDs demanding funded residency caps. I guess adapt or society will route around the shortages. The next reply, if by routing around you mean patients getting suboptimal care, which puts their lives at risk, then I guess that's what the market wants. Residency caps have been an issue for 30 years. It's not new. It's more due to the caps tied up to politically charged Medicaid and Medicare. This brings me back to my thesis around LLMs that you've heard here on the Doc Buddy Journal. In some instances, the extreme power and leverage that an LLM can provide for you is a solution in search of a problem. Not all the time, not every time, but enough of the time that you kind of scratch your head and go, what are we really talking about here? If we're looking at moving the responsibility of care from a physician to a machine, and to a machine which is not all that difficult to trick or not all that difficult to spit out an inaccurate response or a response with no basis in anything, then we're in big trouble. That is not what the market wants. That's not what the market wants at all. I just can't imagine. Okay, so we're getting a little long-winded. Like I said, that might have been more B-roll type material than actual podcast episode material. I'll, of course, include a link to this tweet thread in the show notes, in the episode description. You'll be able to take a look at it. If you're active on Twitter, you can put your own 2 cents into this thread that's gotten just about 2 million views at the time of recording. If you do have any thoughts, or if you think that I'm off base, be sure to tag at DocBuddyApp on X if you do make a reply. Again, this is not a critique of Will or any of his ideas, but sitting here sort of both on the entrenched health IT vendor side of things for a lot of my career, and now providing our own disruption with DocBuddy, I can see it from both sides. I think that the thesis that LLMs will underpin this revolution in care delivery, I don't see it. Not unless something drastic changes with the liability of patient outcomes. Not unless something changes drastically with the availability of physicians, which is, of course, a problem. We want to keep them happy. We want to keep them practicing as long as they can, just for the overall benefit of the system. Obviously, individuals will be free to make their own choices with their own careers and when they decide to hang it up. But very interesting food for thought. And Will, open invite if this is something that comes across your desk. We'd love to host you on the episode. We can get some clarity on some of these points. We can talk it through. Really am grateful that there's a lot of smart folks thinking about healthcare, about health IT, and ways that technology can improve the experience for both physicians, patients, their organizations, and potentially even lower cost for payers as well, so much as it fits into this parallel care delivery mechanism that is being defined as largely cash based in Will's thesis. And on behalf of the entire DocBuddy team, thank you for listening. Be sure you're subscribed on Apple Podcasts or Spotify if you like the audio only. If you like the video component, be sure to subscribe on YouTube as well. We hope to see you at Becker's ASC event next week in Chicago. You are welcome to reach out to me, Eric at DocBuddy.com, ERIK at DocBuddy.com, if you'd like to set up a one-on-one meeting while we're all together in Chicago for everybody in ambulatory surgery center land. And until next time, I'm your host, Eric. Talk to you again soon.